So, Peter, good afternoon. Happy Friday.
Indeed.
Um, so, I wanted to kick off starting close to home. Um, Probably about a week ago, you and I were having a conversation, and I was tentatively hoping that the death rate would stay under 200, and that there might be some anomalous good news in the UK. And alas, we find ourselves where the highest numbers of deaths reported thus far, have happened today. So, just give us a little bit of a sense of where you think we are in the cycle in the UK. Obviously, hard news to be confronted with today.
Yeah, it's been obviously a really hard couple of days for everyone, obviously, for especially for those who have lost loved ones. And I mean, there are a lot of grim milestones. We passed 1 million reported cases yesterday around the world. The UK's death toll now is higher than the reported death toll in China from COVID-19, which is also stark in a country that's a fraction of the size. So it's tough. As we talked about a few days ago, whatever we see today is a reflection of what we were doing 3 or so weeks ago, maybe even up to 4 weeks, particularly with deaths, because the time from when you get infected to when you start to get sick to when the disease progresses is at least about 3 weeks. So in some ways, the developments we're seeing this week, tragic as they are, we sort of knew they were coming, and the verdict was foretold weeks ago, when we were mired in a herd immunity debacle and other kinds of things. That's when we should have been intervening to do this. So we expected this, despite all the great efforts that everyone has made around the country around social distancing and everything else that's been going on. So if we think about where we're at, real social distancing here in the UK started, I would say, about 2 weeks ago, when we kind of closed bars and pubs. And the following Monday, about 10, 11 days ago, was the quote unquote lockdown, which looks like it's actually been working pretty well. If you've been following the kind of, the city mapper reporting about the movements of people and things like that, it looks like we've done a really good job collectively of slowing down and staying home, and that is going to bear fruit. So we hope that we'll start to see that around a week from now, that we might start to be in a place where we could see the beginning of kind of a peak or a plateauing. Maybe or maybe not before then. It's hard to know. And of course, we can't trust the reported cases number because we're not testing most people who have disease. So I think most likely is we'll continue to have some really difficult days with some staggeringly high death tolls, and we'll continue to, of course, see difficult stories about what's happening in our hospitals and with the NHS. We haven't solved PPE shortages and things like that. Some good news today, the Nightingale Hospital was opened. It was great to see the Prince of Wales both back and looking well after having been infected himself. And of course, seeing that facility open, that's going to be almost an overflow space for less severe cases. The folks who need ICUs and things will sort of stay in the real hospitals, but that capacity hopefully should be a big boon, and there are a couple of other hospitals like it around the country under development. So these kinds of things hopefully will help us to weather the surge and make sure that not too many of these severe cases are going to progress to casualties.
From what you've been hearing, just even anecdotally, you have a lot of kind of friends and colleagues who are, in the health sector. Are hospitals really, really slammed? I mean, are we at capacity? If we are at, 600 or 700 deaths a day for the next 7 or 8 days, that means also that you've got that backfill of severely ill people, um, you know, going into hospitals. Are we at that peak moment where there's sort of these very tragic triages having to be carried out in the corridors, or are we still at the place where there's capacity? What are you hearing?
It seems like we're just about on the precipice. A lot of it's anecdotal. The government's saying that there's still a little more capacity left. Obviously, the big surge has been in and around London, and that's where the cases are really overwhelming, and we're seeing some difficult reports. Cases are ticking up a lot in the Midlands, and that may be sort of the next place. I haven't heard lots of reports of the sort of, catastrophe medicine triaging of having to decide which of two patients gets the one ventilator that's left. So hopefully we're not quite there. And hopefully, of course, this increase in bed capacity and the other reports about the health workers that are coming out of retirement to reinforce will help us extend that a little bit further, because we will see a surge continue. If you look at the trends in Italy and Spain, the similar countries a couple of weeks ahead of us, it's not like even when they started to peak that everything suddenly got a lot better. Spain has continued to have really high death tolls because they kind of crossed that point. And so it's going to be probably a several week period of the so-called peak when our health system is going to be strained potentially to a breaking point. So I think we're not quite there in London perhaps, but we're right on the edge. Other thing, of course, that's really concerning is the continued lack of PPE for health workers. It was reported that a second nurse passed away today, and that's the 7th NHS health worker to die so far. We know that there are thousands more who are self-isolating with symptoms. We don't know how many of them are sick because they're largely not being tested. That's obviously a real tragedy, but also I think is going to be really dangerous for our ability to cope, because you can have all the beds and the ventilators in the world. If you don't have enough staff to operate them and actually give the care, it doesn't matter.
You and I were talking before we came online about this debate around masks and about the kind of guidance, potentially coming out of the US, but also in other contexts of whether people should in public, just as a matter of course, be wearing masks now and perhaps into the foreseeable future.
Mm-hmm.
Tell us about the science of that, the advisability of that. Is there any downside to it? Should we all just be, just doing it anyway? What's your view?
The current view is won't hurt, and it looks like it might help a little bit. And so why not? I guess the answer to the why not is we don't have enough masks, even for the health workers who need them the most. And so that's the kind of downside that we can come to. This isn't, some people sort of think that all the public health experts, were lying to you when we said, don't wear masks, they don't help very much. Don't wear masks if you're healthy, they don't help very much. And it'll just sort of send a weird signal and take them away from health workers. What's changed about our understanding of this disease over the last couple of weeks is a couple of things. One, asymptomatic transmission, meaning people who are normal, feeling good, walkie-talkie, who haven't had symptoms yet or might not get symptoms, are very contagious. And actually, the more we look, the more we realize what a big driver of the epidemic are asymptomatic transmitters. And so I can feel amazing and go to the shops for a dozen eggs right now, and I could infect somebody else without knowing it, and 2 days from now get sick. So that's important, and there's no other way to kind of predict that. You can't test for it, etc. The other thing is that, though the jury's still out on this, that it looks like the virus is kind of more and more contagious than we thought it was, that it seems to sort of even kind of breathing could allow it to kind of be aerosolized temporarily, that it tends to hang around in the air a little bit more than we thought, that it might project a little bit further when we cough and sneeze than we thought. And so for all of these reasons, particularly for the latter ones, you kind of say, well, just 2 meters of social distancing actually might not be enough. So if we are going to be even occasionally going out, and those of us who have to go to work because we're key workers in particular, that could be a risk. So I think that's leading to this shift. And overall, I think things have tipped, the scales have tipped towards saying masks for everybody or covering your face for everybody is probably a good thing to do. The question now is just, will this have unintended consequences if it creates a panic for masks when there's already a global shortage for health workers? And are there some other ways we need to think about doing this? So if you're thinking about it, there are some amazing recipes, if you will, online for how to kind of make your own mask, what kind of materials to use, how to sort of sew them together. There's 3D printing formulas if you happen to have access to a 3D printer in your living room. So there are ways to do it without buying medical grade masks. And even just covering your sort of mouth and nose in some way when you're out and about is probably still good enough.
So for people out there who are thinking, I'm going to avail myself of the mandated or permitted once a day exercise regime, and I'm going to go out for a run in a park, and I'm going to do keep a wide berth from anybody, or I'm going to take my kids out on a bicycle ride, it's probably best practice, even in those circumstances where you're out and about, to wear a mask.
I would say if you're working outside of the house because you're a key worker, hopefully that's the only reason. If you work in a supermarket or you're a delivery person, obviously a health worker, whatever, that you wear a mask. I would say if you're going to the shops, and hopefully you're doing that as little as possible for essential stuff, that you wear a mask. I think the recommendations are going in the direction of just wear a mask when you're out and about. I'll just tell you what I'm personally doing is wearing a mask for the former. When I go for a jog, I haven't been wearing a mask. It's hard to wear a mask when you're sort of panting and breathing heavily. And what I do there is say, well, I can keep a lot of separation from everybody else. I'm not in London, central London, so the streets are emptier. But there I feel like, it's not necessary.
Let's talk a little bit about some of the you always try and talk about treatments and vaccines. And again, you were saying, some things which are looking interesting and promising. What's your top of the charts of things that may hold promise, inshallah?
Sure. So first on the vaccine front, interesting report yesterday out of Pittsburgh about a really new kind of vaccine that sort of takes crushed up bits of virus and puts it in this really cool delivery system that looks like a little Band-Aid or sticker with these microscopic needles of the proteins of coronavirus that absorbs into your skin. And if you remember, like anyone who has been around long enough to remember what smallpox vaccination looked like, there'd be sort of these little scratches in the skin. And that's actually because transdermal injection gives the biggest immune response, more than like a regular shot or a regular jab. And so there are like hundreds of these microscopic needles that go just below the surface of your skin. And in mice, it generated a really strong immune response, one that we think would be equivalent to immunity. That's very promising. It's obviously an animal study, so it needs to be tested in humans for safety, and there'll be some steps for that. So that one is not a tomorrow thing, but it's a great example of the promise of really kind of path-breaking science that might be really effective. This, of course, is one of dozens, as we've talked about, of vaccines of all shapes and sizes that are being developed and tested and rolled out around the world. I'm actually on Sunday going into the Churchill Hospital here in Oxford to enter as a subject into a vaccine trial, one of the first 500 people to do human testing on a vaccine that was adapted from some other vaccines. So human testing of a vaccine will begin in England, actually began this week, but I'll be one of the first. So excited about that. I mean, we'll see. So I think things are marching forward. I guess the other thing that we're seeing there is, we've talked about how no matter what you do, there are these steps you have to go through to make sure that things are safe and effective before you do it. What we've seen over the last couple of weeks has not only been like a massive surge in new research and development, but also really smart thinking about how to condense that timeline by kind of overlapping and doing things at the same time. Finding places where you can say, actually, we can skip animal studies and go straight to careful human studies, or we can overlap a phase 1 and phase 2 trial at the same time. And while we're doing those things, we can actually find investment to start manufacturing all of the base ingredients that we would need to manufacture this vaccine at scale. So if it actually is shown to be safe and effective, it wouldn't take 2 years to start making enough to make a difference. And so we're going to start seeing investment that are betting on some of the more promising vaccines so that you could make hundreds of millions of them relatively quickly if one of them kind of gets over the finish line. So that's all really exciting. On the drug and treatment side, millions of trials, nothing that's blown my mind so far. I retain hope for kind of existing drugs that are being trialed, like hydroxychloroquine, though I think that's overblown, remdesivir, because those have already been shown to be safe. If one of them works, we can get to it a lot more quickly than some of the newer drugs that are out there. And the antibody therapy, that taking serum of someone who's recovered from infection and giving it to others, all really small studies, but they've all been very promising so far.
Peter, let me ask a sort of over the horizon question, which is, if you think of all in this period up to now, all, the kind of domain that has been in people like you or the Gates Foundation, who've been dealing with public health crises in the global south, no real pharmaceutical market, not much interest in it other than curiosity from well and wealthy people in the north. But a concerted group of committed people with good foundations trying to do incredibly heroic work. Is it conceivable that this global crisis, unprecedented as it has been, will surge resources, research, all the innovation that you've spoken about, all the ways that you respond to this particular pathogen, but then by association, many, many others that are linked to it, so that in 2 years' time, we may be in a world where many other neglected diseases or sort of areas of the public health world that were unfashionable and sort of niche now come to the forefront. And is it possible that therefore that we may be in a world where we are seeing millions of people who would have died not dying because we've made an investment that we ought to have in a more moral world?
Yes, I think so. I think it's already been happening to some extent. If you look over the last 10 years, Gates has been a big part of this, understanding that diseases that affect predominantly poor people aren't going to get fixed unless somebody takes it into their hands to realize there's a market failure and find a different way to fix it, right? That's the reason that for diseases like leprosy or drug-resistant TB or river blindness, we were using, practically medieval drugs that were invented, in the 30s or 40s or sometimes the 19th century. And that's changed a lot through investments in what are called neglected tropical diseases, or NTDs. So to some extent, I think a lot more attention and investment has been made into those things. And that's already, I think, making a big difference. I think this will push it further, and it will particularly around finally maybe starting to take a proactive stance on the risk of pandemic infectious diseases, right? So we didn't know that the pandemic that we're in right now was going to happen now, or that it would be caused by this particular novel strain of coronavirus. But we knew that it would happen, and we knew that when it did, it would almost certainly be a virus that exists in animal populations that has the potential to jump over because it's similar enough to stuff we see, right? So you can imagine a bunch of smart scientists who could catalog all of those viruses out there and risk stratify the viruses that are more likely to kind of jump over and mutate and infect humans. And why not then start a pipeline of development of vaccines or therapies for some of those clusters of kind of the highest risk viruses that could be the next COVID-19. And then you have a jump start on this, right? And we look back to SARS, of course, and like a lab in Texas, I think I mentioned this last week, run by Peter Hotez, was really close to having a SARS vaccine. And then a couple of years ago, all their funding dried up because SARS had been gone for a while and they just couldn't finish it. They've started it up again, but they probably would have had it if the funding hadn't dried up. So we haven't learned this lesson in the past. I'm optimistic we will this time. And some groups like CEPI, the Center for Epidemic Preparedness and Innovation, are charting a real roadmap for how to do this. So I think we need massive investment to do this well, and to do it in a thoughtful, coordinated, joined up way. But hopefully people will realize that that kind of investment is a heck of a lot less expensive. It's a fraction of the cost of propping up the global economy when things fall apart as they are now.
And let me ask a follow-on to that, which is, you said when people were modeling it out, they couldn't say it was this kind of novel coronavirus, but they thought it was going to be a virus. Is there not an argument that as large, if not greater, a threat could come from antibiotic resistance? And, we've been modeling that out, and everybody's been going, ooh, that's going to come. And both in terms of the overuse in human beings, but also more importantly, in animals, which we then eat. And there's, in terms of building back better, which is our big mantra right now at the Conduit, building back better after this should not just be about making sure we have pandemic preparedness for these kind of viral threats, but there may be some kind of bacterial or antibiotic resistant threats which are as significant and that we need to get ahead of, and that may have food industry consequences.
Yep.
And there may be some kind of helpful things there in reforming battery farming or industrial level farming, and this could be a Trojan horse, as it were, into trying to reform some of those practices.
Absolutely. I think you've hit the nail on the head. It's not something that most people are talking about right now because it's different. But if you were to list the big global threats that are kind of out there and looming right now, I think pandemic disease is always there, and there's always the risk of another. And that could include sort of biological terrorism, right? Somebody putting a virus on a drone and then, spraying it over London, New York, et cetera, et cetera. Climate change obviously is right up there. I think you could argue that sort of the attack on liberal democracy at the moment is right up there, and I'd put antibiotic resistance in that same category. There are already strains of certain bacteria that are not treatable by any existing antimicrobial agent or antibiotic that we have, and that's scary. And oftentimes they're kind of obscure, weak pathogens, but you can see how it doesn't take much for those genes can jump from bacterium to bacterium for that to happen, and something that was really contagious that we couldn't treat at all. So we need both, I think, reform in things like factory farming and animal agriculture, because that's a huge driver of it. We also need frame shift, quantum leaps in scientific discovery in terms of how we actually manufacture antibiotics, develop new ones. And that's possible because of genetic sequencing and CRISPR and lots of other stuff. So it's another place that I think has not received enough attention or investment. And maybe we should be beating the drum for it. I'm with you, Paul.
Okay. Project for when we get the hell out of this problem. Question.
Walk and chew gum at the same time.
Exactly. Another question for you on we've dealt with the UK, and you mentioned a little bit this question of immunity passports, and I wanted to get a sense of there's some thinking, maybe fanciful or maybe science-based, on how we get out of this, that a group of people get tested, they have immunity, you said you have immunity, and therefore you can go back to work. And Matt Hancock has been suggesting stuff around this. Give me your take on this pathway out of it via immunity testing or immunity passports.
Yeah, the thing that made me really happy about hearing Matt Hancock mention this yesterday was it showed that they are starting to think about what's our strategy to get out of this, right? Lockdown is just a time-buying measure. It won't solve the problem. We can't be in lockdown forever. So how do we come out of this, or begin to come out of this in some way that is not going to allow for another big surge in infections? Obviously, once we get this under control, but maybe come late May, early June, hopefully we'll be on the other side of that peak. What happens next? And there are a lot of different things I think that need to happen for us to think about how to do that. And we're all going to be learning as we go, because no one has figured this out yet. But certainly an important part is going to be to first have a better understanding of immunity, right? After you get infected, we're pretty sure that the risk of getting reinfected is very low, at least in the short term. No one who's ever had this has been recovered for more than about 4 months because it's new. So we don't know what immunity means and how long it lasts, but we're pretty sure that there's some immunity after you get infected. Then can we say, well, who has immunity? How many people have immunity? Where are they? And could they help us get society back on track because they can safely go out and about and kind of operate? The place that's most important, obviously, is for health workers and other critical workers who are being decimated right now by the virus itself. And so being able to say, you've been infected, you appear to have immunity, you can get back to it, is going to be really, really important. And so, that's one of the reasons the government is they made a big bet. There are two reasons the government has made a big bet on antibody testing. One is they totally missed the boat on regular diagnostic testing for the active infection, and now they can't get it anymore because there's a massive global shortage. And so day after day, they'll sort of release these lofty targets and their grand plans, and they can't deliver on them just because they got in the game too late. The other reason is that there's potential promise for this. So that's really good. What's the downside? There's real potential unintended consequence here. One is, I think the idea of calling it an immunity passport or certificate is fallacious, because it's not immunity, it's just the presence of antibodies, which we hope means some immunity, but we don't really know. Imagine a scenario in which you've got two workers in the same company. One of them, and they're both stuck at home and they're not able to work from home, so they're just out of work right now. Maybe they're furloughed. One of them has an immunity certificate because she was infected. She's allowed to go back to work. The other guy isn't allowed to come back to work. What happens, right? Is that fair? Is there a discrimination issue here? What's the likelihood that that guy is going to say, you know what, I need to feed my family. It's been a month. Screw this. I'm going to try to get infected. I'm going to find someone who's sick and get infected. Or I'm going to find someone who can do the prick for me so I can get a certificate so I can get out there because I need to feed my family, even if I don't actually have that immunity. So you can see all the different ways this could get really, really complicated if you started having this two-tiered society where there's like the immune and the non-immune, and the non-immune are all like quarantined and locked up, and the immune get to go and have economic opportunity, etc. It's not that it's not addressable, but we better have a plan for it, and that's what needs to come next.
I think that the ethical conundrums in that are just massive. You're a conduit member, and I was just thinking, doing this exercise in my mind, saying, should we try and do as a service to the conduit community to try and procure testing for everybody so that everybody who came into the conduit could be tested? And then I began to start thinking about that, which is, so would you make it a prerequisite that anybody who walks through the door has had a test? Would you make it a prerequisite that anybody in your staff has either had a test or has an immunity passport? When a member comes in, you bring in a guest, unless you have an immunity passport, have had a test, have shown that you've had it, and your guest has had it. And if you think about that just for our community, and then amplify it across giant companies and what it is to leave your house, it does start becoming very practically difficult to operationalize and ethically questionable, because different people have different access and can pay and can't pay. And
Paul, you lived in South Africa where once upon a time people had to show their papers, and you could or could not pass or get into certain things depending on what your papers said. I lived in Rwanda for a long time where you had to show your papers, and if you were in one group, you couldn't go to school, you couldn't get a job, etc. And this has echoes of that. I know it's not the same, but when you start sort of tiering society into haves and have-nots in any way like this, I think it's dangerous. So there's a lot to figure out on this.
There's a related and perhaps a final question to you is, it goes to this question of asymptomatic transmission. Can you be asymptomatic for longer than 14 days? And the reason I ask that is, could you have people, let's presume everybody locks down perfectly and then everybody then at the end of that goes out except for the ill. Could you have people who've been locked down for 14 days who had no symptoms but have it asymptomatically and then give it to others? Or if you don't show symptoms within 14 days, you're unlikely to have had it?
I don't think we know the answer to the question for sure, because it's really rare to even be able to diagnose asymptomatic people, and there haven't been studies that have been able to sort of follow them.
No.
Most of what we know about asymptomatic transmission is when you look at the time it takes from when I got sick to when the person I infected got infected, and it's shorter than the incubation period, if that makes sense. So we don't know. In general, most people clear their infection within 14 days of having symptoms. Sometimes that goes a little bit further. I don't know the answer to your question. I don't think anybody does. That said, I would be surprised if contagiousness or infectiousness 14 days after getting infected, if you never had any symptoms, I doubt that's going to be a big problem.
But could you fall ill 14 days? Could you be asymptomatic and then fall ill?
Most people who fall ill after being infected do so a median of 5 days after being infected. And the majority of it is really between sort of 4 and 7 days. So I doubt that somebody could sort of asymptomatically carry around the infection for 2 weeks and then suddenly get sick.
Good. Peter, it's beyond the witching hour. It's 6:03. So I wish you an excellent weekend. You are drinking a Corona beer, which has got to be demonstrate that even in these hard times, we have a sense of humor and a sense of joy in the world. It's fantastic to see you again, my friend, and I cannot wait to doing it in person. But have a good time. Stay safe, stay well, have a good time with your family.
Thank you. Same to you. Good to see you, and have a great weekend, everyone.